Good morning. My name is Laura Lefevers. I'm a family nurse practitioner, and I'm going to be presenting on mild to moderate severe antenatal unipolar depression. So first off, I would like to say there are no financial disclosures. And the objectives of this talk are to describe the symptoms of mild to moderate severe unipolar depression of the pregnant woman. And two is to list the different treatment options for treating pregnant women with mild to moderate severe depression. So let's start with the definition of unipolar depression. It's actually quite common in pregnant women and often goes untreated. And the difference between pregnant and non-pregnant women who actually are likely to receive treatment is between 49 to 57%. So the diagnosis of unipolar depression is really no different than in the pregnant woman versus the non-pregnant woman. But one of the characteristics would be that they have to have 5 of the 6 depressive symptoms for a minimum of 2 weeks and no history of mania. And those 5 symptoms consist of depressed mood, loss of interest or pleasure in activities, insomnia or hyperinsomnia, change in appetite, in weight, psychomotor retardation, decreased energy, poor concentration, guilt, thoughts of worthlessness, and recurrent suicidal thoughts. However, if they are currently exhibiting suicide behavior or they have impaired function, then that would trigger a more severe major depressive disorder. So the PHQ-9 is definitely one of the best tools to use, and they would need to score less than 20 to be in that category of mild to moderate severe depression. So when we talk about the treatment, let's look at the general principles for treatment. And of course, the treatment of depression will depend on the severity of the illness, their comorbid conditions, and if they currently are receiving or have received treatment in the past. But you want to think about, in the principles of treatment, the setting in which the patient is being treated. Oftentimes, this may be the first identification of a major depressive disorder when they're identified as being pregnant. And they often want to be treated by their OB provider, that's okay. However, it's more efficacious if they could be treated by a collaborative team, and that would include your behavioral health specialist or mental health counselor and primary care provider. Also consider the history of prior treatment. If they currently have been treated for depression and they're currently on an SSRI, a selective serotonin reuptake inhibitor, then you would want to continue that treatment. And of course, any psychotherapy treatment that they've had in the past would be important to continue. Educating patients and families, this is important to educate them about the symptoms of depression, the course of the disease, the treatment options, and the potential of risk of not being treated for depression. Adherence, this is important to make sure that they are adhering to their treatment, but for the provider, it's often frustrating because we need to manage our expectations that adherence is poor, and it's usually due to the cost of treatment, the logistics, and lack of trust in the medical system and stigma of depression. Also, it's important to monitor the symptoms on a regular basis, and this can be done at their prenatal visits. Usually, it's recommended to administer the 10-item Edinburgh postnatal depression scale. This covers a lot of the physiological symptoms of depression and pregnancy, including appetite, fatigue, energy level. And alternatively, you can use the PHQ-9 scale. Prescribing antidepressants, this is really the most common form of treatment, and we'll go into that on the next slide. Managing non-response is important. If you feel that they're not really responding to the current treatment plan, then revisit whether or not this is a major depressive disorder, or if there's some other significant life stressors, other comorbid psychotherapy or psychopathology is like anxiety, substance use disorder, personality disorder. And then making referrals. And this is important to recognize when it's time to make a referral. Often OB and primary care providers are very skilled at being able to treat major depressive disorder. But if the patient is requesting to be referred, or if you're starting to see escalation in their behavior with aggression or suicidal ideation or impaired functioning, then that would be appropriate to refer them to the psychiatrist. So moving on to approach to treatment, the most common form of treatment is going to be the pharmacotherapy. And this is always concerning with a pregnant woman because of the risk of fetal exposure to the medication. But it is quite common to use antidepressants in the antenatal period. And in fact, in the US, the treatment of pregnant women with pharmacotherapy is between 7 and 8% of the pregnant population. And in Europe, it's around 3%. Antidepressants should be considered with psychotherapy. It's been shown that one or the other treatment alone is not as efficacious as if you do the combination of treatment. And when you're looking at pharmacotherapy treatment, you want to think about the risks that it poses to the mother and the fetus. We know that the SSRIs are the most common antidepressants used during this time period. And they do cross the placenta and fetal blood-brain barrier. And there are some adverse consequences, such as preterm birth, low birth weight, spontaneous abortion, postpartum hemorrhage, postnatal effects. And most of the studies that have been done have been observational studies, and really there have not been any good randomized trial studies. So you want to try to minimize the risk of exposure to the fetus by starting with a monotherapy and starting on a low dose of a SSRI. And initially, it's recommended to start with sertraline. Alternatives to that could be citalopram or escitalopram. Now, if you find that those are not being effective or they're not effective, then it would be important to switch to a different SSRI if they're not responding to the treatment versus changing classifications of medication. Also, weighing the risk of not treating the depression, because most women are really concerned about the effects that medication will have on the development of their fetus. But when you look at the effects of untreated depression on the fetus, you could have things like anorexia, poor nutrition, cognitive impairment, anhedonia, poor self-care, non-compliance with prenatal and postnatal care, and also postnatal depression. So SSRIs are relatively safe. They're considered grade 2B, and the risk of SSRIs and treatment with pharmacotherapy is really minimal risk to the fetus and the mother. I also like to stress and manage the expectation of the patient to recognize that treatment will probably continue not just through the antenatal period, but in the delivery and through postpartum. So that completes my talk. At this point, I would ask the audience any questions. And I have my resource list listed here in this slide. And I appreciate the opportunity to do this presentation. Thank you.